So today we're going to talk about weight loss, uric acid, and this thing called a pound-out study, and I promise I will go over that more with you. So just for an overview, we're going to spend about 10 minutes talking about uric acid. You probably never knew someone could talk about uric acid for 10 minutes, but hopefully I'll make it interesting. 5 minutes about the two drugs that we're using in our randomized controlled trial, and then hope to spend maybe 5 or maybe more minutes talking about some of the initial results from this study. So to get everyone on the same page, what is uric acid? If you remember way back into your biochemistry days, there are 4 little elements that make up DNA, and adenine and guanine are the purines. The problem with those is they have a 6 bond and a 5 bond, and the body can't really get rid of those. Like some other animals, fish, amphibians, we don't have uricase. So when those purines get broken down either by breaking down DNA or making new DNA, you get hypoxanthine, xanthine, and then uric acid. In general, most people make about 400 milligrams a day of uric acid that has to be released. So in addition to that endogenous uric acid, there are other ways to have uric acid in your body. One way would be to eat a large piece of tenderloin meat served last night in a gravy. So about 3 ounces of meat is roughly equivalent to about 50 milligrams of uric acid. And then there's a lot of other things that contain DNA and uric acid as well. So in general, most people ingest about 400 milligrams. So this means about every day your body has to get rid of 800 milligrams of uric acid. So fortunately, we all have kidneys, we all have guts. So about 3/4 of it goes out your kidney, about 1/4 of it goes out your intestinal tract. So if you have gout or hyperuricemia, too much uric acid in your body, one of the first things we tell those people is to lower your purine intake. And if you've ever heard of that 6 to 9 ounces of meat a day, no more than 6 to 9 ounces of animal protein, look what that calculates to. So that's somewhere between 100 and 150 milligrams of purines. So it's really kind of interesting how those things come about. But that would be a low purine diet. So that's one way to get rid of uric acid or in your body. The other way, of course, is pharmacologically. That's a lot easier and a lot more tasty, I guess. So this would be allopurinol and all the sister drugs associated. These are xanthine oxidase inhibitors. You inhibit the downstream effects, and so you basically get a lot of hypoxanthine, which is very soluble in the urine. So you go, well, that's great. So maybe we should just put everyone on allopurinol, right? But unfortunately, uric acid stones is not a uric acid problem. It's actually a pH problem, and I'll show you why. Again, going back to biochemistry, the pKa of uric acid in the urine is 5.35. So if you guys remember, the pKa is the point at which you either give up or accept a proton. So anything above 5.35, you start pushing this reaction more towards sodium urate, which is highly soluble. So 5.5, 6, 6.5, the higher the better for most of these folks. When you start going below 5.3 is where you start solubilizing uric acid, and that's where you get uric acid crystals and stones. So it's about 10% of all stones in the United States are uric acid, and another 5 to 8% of those are mixed with calcium oxalate. And the thought is those little uric acid crystals, oxalate, calcium stick to those, and that's your nidus for stones. So there is an association with gout, so I don't want to downplay that. I think it's probably more of a historical association now that we know more about the pathophysiology, but really the biggest association is metabolic syndrome, obesity, and diabetes, and it's really an ammonia-genesis problem. So I promise this is the only cartoon of the proximal tubular cell I'm going to have, but I think it's important just to mention this because this is on boards. So ammonia-genesis happens in the mitochondria, and these people have ammonia-genesis problems. So all you have to remember is glutamine makes ammonia. Ammonia is NH3. I don't know how well you can see it, but there's a little green NH3 that gets transported out into the urinary space. That NH3 binds with the hydrogen and makes ammonium, and that's your buffer. So we all hang out, most of us, around 6.2, regardless if you had a big steak last night or not. Well, when you have ammonia-genesis problems, which diabetics do and patients with obesity do, you no longer have that ammonia, so you don't make ammonium, and you have all this extra hydrogen, and you have a pH of 5, if that makes sense. There are probably 30 studies I could have quoted showing this relationship. This is just one published in JASN about 15 years ago. Michel Dodon is a French urologist. They looked at a commercial lab in France and just showing you the relationship between the blue bars, that's the patients with diabetes, and as their BMI went up, the rates of uric acid went up. In fact, it was about a 6-fold increase in diabetes associated with uric acid stone formation, as well as some smaller associations with BMI and male gender. So you say, Canales, I kind of sort of get the 5.3 thing, but I want to show it to you a little bit better. So this looks complicated. I'm going to walk you through it. So this line here is the most important line on the whole slide. That is the supersaturation of uric acid. So any point above that line, uric acid is going to come out of solution and form crystals. So we're going to take Mr. Red. Mr. Red has a uric acid concentration of 200 milligrams per liter. Normal is 750. So this is incredibly low, right? I mean, this person has almost no uric acid in their urine. So there's the line. But with a pH of 5.2, look at that. Mr. Red meets above that supersaturation area for uric acid. This guy is supersaturating uric acid crystals and may make uric acid stones. Mr. Blue has a very high uric acid level, 1,000 milligrams per liter. It just sounds terrible, doesn't it? He's all the way on this other end in this blue range, which is the abnormal range, blue end of the spectrum. But his urine pH is 6.5. Guess what? He's not supersaturating for uric acid. So it almost doesn't matter what your urinary uric acid level is. It all depends on pH. All right. Say, well, wow. Well, that's easy. Why is this even a disease? Let's just alkalize the urine. What's going on here? And I'm telling you, the NIH for years has said this. Any uric acid grant, they go, well, just alkalize the urine. What's the big deal, right? We don't need to know mechanisms. Just give people lots of base. And that's easy to say, but it's much harder to do. For those of you who have obese diabetics and uric acid stones, you guys know this. 8 to 10 pills a day of sodium bicarbonate. That can maybe for a day or a week, but more than a month is pretty intolerable. Potassium citrate, which is much more effective bicarbonate than baking soda, is about like swallowing half your pinky finger. Most studies show patients discontinue pretty much around 6 months. This is no longer covered by Medicare, so there's now a cost issue. And then, of course, the first part of this is potassium. So potassium citrate and hyperkalemia is a concern. A lot of these patients get GI upset as well. And we already mentioned why allopurinol doesn't really work, because it doesn't change the pH. So you're saying, Canales, you're throwing a lot of curveballs here about alkalinizing the urine. Why don't we just take it a step back and just get this ammoniogenesis problem resolved, and maybe these patients will do better. So let's talk about that. So what works for weight loss? And I'm putting stuff here of long-term weight loss, not 1 month or 3 months, which we all probably did for our New Year's resolution. But long-term, 1 year, most people it's a wash. In fact, if you look at studies, we usually gain about 1% of our total body weight every year. Xenical came out about 20 years ago. It's been around for a long time. It's about a 2% total body weight loss. Belviq, which is no longer available, came off the market a few years ago, is 3%. Phentermine, Topiramex, or Qsymia has about a 10% total body weight loss at 1 year and the 2-year trials. Contrave is about 5%. Some of the newer GLP-1 agonists, Saxenda and Ozempic in pill form, and there's now some extended release forms, is about a 5% total body weight loss at a year. And then there's some older generics on the market. So about 4 years ago, this one really struck me because there's a couple of unique side effects of this medication. So let's go into it a little bit further. So Phentermine, I don't know how many of you here have heard of it, but it's been FDA approved since 1959. It's the most commonly prescribed anti-obesity drug in the U.S. You can literally just go down the street at the obesity center and they will just hand out Phentermine. It looks like an amphetamine, so there's all these warnings, but it's not an amphetamine, it's not addictive. It was part of the Fen-Phen scandal, so it's that second part of the Fen, but you have to kind of reassure people it has no issues with valvular disease like the other Fen. And then Topamax is a carbonic anhydrase inhibitor. It basically calms neurons. So it helps with seizures. That's what it was originally FDA approved for. It helps with headaches. But because it calms neurons, it also helps with with cravings. So addiction medicine specialists use this all the time for food addiction, alcohol addiction, tobacco addiction, and a side effect is also weight loss. The other interesting side effect is it blocks resorption. It's a carbonic anhydrase inhibitor. It blocks resorption of sodium and bicarbonate. So you basically get bicarbonuria. Your kidney dumps bicarbonate. So this is a little busy. I will walk you through it, but I wasn't the first to think about, hey, let's use a carbonic anhydrase inhibitor to raise someone's pH. This is a study published in 2008 in a group of patients with uric acid and cystine stones that they just couldn't get the pH up. So they added acetazolamide. This is been around since the 1960s, and what they saw was a dramatic increase in urine pH when they left these patients on their potassium citrate. And then I've just listed 2 other studies, there's several others, where they took someone before they started Topamax and after they started Topamax, and in general, you get a urine pH increase of about 0.5 to 1.3. In addition, if you look at these 3 studies and a couple other studies, you're also dumping a little bit of salt, which means fluid follows, and so you get a little diuresis. You're like, this is amazing. Why don't we just all get on, acetazolamide or Topamax, and we're going to have, higher pHs and more urine volume, and we all cheer. Well, the downside is you're dumping bicarbonate continuously. So eventually what ends up happening is you get acidotic. Just a little bit acidotic, but it's enough to raise the alarm bells in the kidney. The kidney says, oh my gosh, you're acidotic. I'm going to hold on to citrate because citrate is a very strong alkali. So most of these people, in fact, every study that's been shown, that's been published, shows that Topamax decreases urinary citrate. And probably for the everyday Joe, this is not a big deal, but for stone formers, it's a big deal. So you have this kind of yin-yang effect. Pound out stands for phentermine topiramate to end obesity in uric acid stones trial. They're actually acronym generators online. If you guys are ever interested in making your own acronym, they actually help. So this is an open-labeled, randomized controlled study. We started it, we were actually funded 3 weeks after COVID started. So it literally took us a year to get this off the ground because we couldn't recruit patients. But we're recruiting adults. In fact, we're supposed to end recruitment later this week. But we're recruiting adults with uric acid stones, and they actually have to have a piece of paper that shows what mineral type they had, either pure or slightly mixed. They have to be obese, and they have to have some form of diabetes. We're excluding anyone with a contraindication to the medications, anyone who's currently on an anti-obesity drug, or anyone with a low GFR. And in the treatment group, we're collecting everyone 24-hour urine off any kind of alkaline therapy. So we want to know what their pH is just on a regular day on nothing. And then in the treatment arm, we're putting them on phentermine and topiramate or Qsymia. And we're telling them, sure, you can stay on your allopurinol because it's not going to change your pH. You can stay on whatever diet you are. We do have a weight loss counselor, a nutritionist, labs, imaging, and we do have some escalating monetary incentives for the patients. The control group looks very similar. They're doing a 24-hour urine off of any of their alkalins, but then they're just getting back on whatever their standard of care is. This has been hard to recruit into the control group because, of course, everyone wants to be on the weight loss pills, but everything else is exactly the same. They still see the weight loss counselor. They have labs, imaging, and monetary incentives. Our outcomes, our primary outcome is really kidney stone growth. We're getting a CT at baseline, and we're getting a CT at 18 months. Our secondary outcomes are everything else. So total body weight loss, changes in urinary parameters on 24-hour urines, hemoglobin A1C, and then we're doing body DEXA scans to see if they do lose weight, where does the fat go? If it's from lean muscle, a bone, or fat mass. So I was really excited when this thing got funded. I went straight to Vivis, which is the manufacturer of Qsymia. I'm like, hey, would you guys give us some of your drug? And they're like, well, this drug costs $3,000 a month. Why would we give you, months and months of it for free? So they were not interested in funding it, so we went generic. So we're actually using phentermine half tablets a day for patients, and then if at 3 months they haven't lost weight, we double their dose. For Topamax, you do have to have a slow increase and then a slow decrease on the back end. 100 milligrams is the standard dose. If their urine pH doesn't hit 6.5 by month 3, we're increasing their dose to 150 milligrams. Above about 200, there's this idea called Topamax head where people start just kind of getting mental issues, so we didn't want to go above about 150. This is study visit timeline. I'm not going to bore you with it. The only thing of interest here is at the very end of the study, I wanted to know, okay, for people who lost weight, did their pH correct? So I did do one 24-hour urine after they stopped drugs and then repeated another one a month later, just out of scientific curiosity, we'll say. So this is our flow diagram. I think this number has changed a little bit. It's just up from one. I think we've now recruited a total of 18 patients, 12 in our treatment arm and 6 in the drug arm. So this is the first that I'm ever showing any of the data because we have just finished enrollment. But in our drug arm, we've got about 2/3 of our patients in both control and drugs are males. There's a little preponderance to being a little bit younger in the drug group, having a little higher BMI, and that of course also correlates to slightly higher hemoglobin A1C. The PHQ 24-hour urine pH of 5.3 and the CT stone numbers are all roughly the same, but in our drug group we do have higher stone volumes by CT, and again that's just a product of randomization. So we have had 2 patients that have completed their 18 months, and I'm going to just show you something briefly on them. So this is our first patient. He weighed 326 pounds when he entered the study. At the end of the study, he'd lost 60 pounds, so he was very happy. His hemoglobin A1C dropped 2 percentage points as well. Our second patient started around 260, and has come down. This is his August study. He actually had his most recent one was 194. So he also lost 60 pounds. So this is not usual. We don't have this kind of weight loss in a lot of our other patients, but the first 2 really banged it out. And then he's got about a 3% drop in his hemoglobin A1C. So this is his 24-hour urine. I'm just going to show you his. So this is where he started. He started at a pH of 5.0. So if you think about that curve, I mean, any uric acid in there is coming out. No wonder he's making uric acid stones, right? So once we started him on the 100 milligram dose, he went to 5.9. We gave him 150. He went to 6.5, which is just the sweet spot, what we like, at least for our study. And look what happened to citrate. Just next door, 387. So his urinary citrate did go down. What does that mean for stone disease? We don't know. A trial like this has never been done. And then at the end of study, when he stopped all his medications, unfortunately his pH was still 5.1. So even though he dropped 60 pounds, his pH didn't bounce back. But maybe somewhere down the road the pH corrects and the immunogenesis problem corrects. But his citrate level did go back to normal once he stopped these drugs. I just wanted to mention we did have some adverse events. These are kidney stone formers. They have active kidney stones. We've had in our control and our drug group a couple of kidney stone passages, a couple of procedures in their control group, and then all kinds of adverse events. Changes in taste. One patient complained of erectile dysfunction, so we had to modify our IRB so we could give him a lower phentermine dose. He really felt the phentermine was giving him ED. We had one lady who took the drugs for 4 days and said, I just don't like the way it makes me feel, it makes my heart race, and so she discontinued the medication. So I've hit you with a lot today. Broad strokes, uric acid is a urine pH problem. If you don't remember anything else from that, remember that in your practice, please alkalize patients. Don't give them allopurinol. Diabetes and obesity associated with immunogenesis problems. Phentermine and Topamax, hopefully I've introduced that to you. Our initial results are very promising, and we hope to have our final results next fall. And I wanted to briefly mention, these are all the folks I work with. A study like this, one person can't pull it off. So nephrologist, dietitian, endocrinologist, statisticians, and then my partners at UF Health. Thank you very much.